Today, this morning, we'll be talking about suicide and suicidal ideation in people with intellectual and developmental disabilities and dual diagnosis. For those of you who don't know me, and a few of you actually I have met before and trained before, so it's nice to see some familiar names, if not faces, those of you who are brave. I am Michelle Anbar-Goldstein. This is the this is the Shared Learning Forum, and today is November 25th. All right, we'll go next. Okay, so we're talking about a sensitive topic, obviously. The topic of suicide can be one that's difficult for people to broach and difficult for people to speak directly about. So I like to do sort of a message of compassion before and some ground rules and some thoughts I have about the whole thing. So some of you sitting in this training today might be survivors of suicide. Some of you may currently be struggling with thoughts of suicide, or you might have a history of suicidal ideation. You may have a loved one who has or is struggling in this way. And you might find that the information that I'm going through might trigger you or hide in your emotions. If you or a loved one is struggling with suicide, there is help available. And I will put it out there. I am happy to speak to anyone at any point. You have my information. Deanna can send out my email address. If at all today you're struggling, please do not hesitate to reach out. If you need help if you need assistance navigating resources in your community, don't hesitate to reach out. There is a slide at the end of this presentation, sort of with some resources that you could use, like crisis resources in this case. If it's available to you, I do encourage you to reach out to your human resources at your place of work and find out more about your employee. What does EAP stand for? Deanna? Employee Assistance Plan.
Yes. Sorry,
yes.
I didn't.
Yeah, it always slips my mind. So I encourage you to do that. And if you're finding this training stressful, I encourage you to take a break. But the important part is that I just ask that you just message and say, and just let us know in the chat privately to Deanna or to myself that you're okay. The same thing goes that if you're finding this completely useless and you don't want to sit through it, fine by me. Just send me a message first, or send Deanna a message first to say that you're okay, because I wouldn't want you to leave distressed without any sort of support. And again, mental health is very much held. You are loved, you are supported, regardless of what afflicts you. And I just want you to know that use me as a resource if that's necessary. So today, what are we going to go through? We'll talk a little about nomenclature. It reminds me, I don't know if any of you have seen The Big Lebowski, but the word nomenclature reminds me of that. But that's a weird Coen Brothers reference that maybe no one gets but me. We'll talk a bit about who I am and how did I get here. We'll have a bit of an introductory conversation. I think we'll have it within the chat box, maybe. Deanna, do you mind monitoring that one? Thank you. It's because she's on the beach. She's not stressed at all. We'll talk a bit about suicide rates in Canada and what we're seeing and what the high risk groups are. Then we'll talk about suicide and IDD. We'll talk a bit about some tips for intervening with an at-risk individual. We'll talk about some supports in the community, steps moving forward, and finally, there'll be some chance to ask questions and get those burning questions answered. But given sort of the breadth of this topic and how much I have to go through, I'll ask that all the questions are saved for later on, if that's okay. Unless it's a clarifying question about something on the slides, in which case, by all means, please ask, because I don't want to move forward without people actually understanding the content. So that's a good thing. So what's next? A note on nomenclature. So here's something. There are certain terms that we use to describe suicide or describe the action of someone trying to die by suicide. So this is just a heads up. So instead of using committed or commit suicide, we're going to use died by suicide or suicided. Instead of using completed or a successful suicide, we're going to use death by suicide. So rather than saying that person was successful in their suicide, we'll just say that person had a death. Hello, good morning. And instead of using failed suicide attempt, we will be using non-fatal suicide attempt. So the reason for all of this, and I know it's a curious one because it seems relatively innocuous to say, like, oh, that person committed suicide, but the the fact of the matter is that it was illegal to kill oneself. And so there are these sort of criminal overtones that really do contribute to the stigma around suicide. And as we'll find out very shortly, that stigma is really a huge barrier, not only to support, but to even our understanding of suicide as an issue, as a health issue in Canada. So, we don't want to equate it to rape or murder. You commit rape, you commit murder, you die by suicide. And then when we talk about this idea of completed or successful or failed, it's really paradoxical if you think about it, right? Like you put a positive connotation on the suicide actually, having the suicide having killed a person. So instead, we'll just use, actually what happened so that it's a non-fatal attempt. Understood? Everyone's good? And honestly, if you make a mistake, I still make mistakes, but I probably will correct you. I'm sorry. So moving forward, this is me. I guess you see me on the screen and this. Who am I? I'm an advocate, I'm an educator, I'm a social worker. I worked in the DS sector for about 15 years before I landed in mental health. Currently, I'm at the Forensic Dual Diagnosis Specialty Service at CAMH. I recognize some of you from the work that I do in that capacity, so hi to all of you. I'll say hi individually later. I'm also a professor with the Developmental Services Worker Program at Humber College. I'm part of the Internal Review Committee at Community Living Toronto. I sat on clinical case conference with CNSC for quite some time, but this year I was very bad, and I'm sorry, guys. Joanne, if you're here, I'm like so sorry. I'm also an instructor for Living Works Applied Suicide Interventional Skills Training. But here's a caveat. This is not that today, right? I'm gleaning I gleaned a lot of the information from that training, but this is by no means are you being certified in this training. But I will say, just a plug for it. It's a very, very good thing. I was involved in like an agency training sort of project with an agency I used to be with, and we trained the whole staff, and it was really great. Something to consider. I mean, for those of you who are working with high-risk individuals. I do consultation, I do clinical work, both individually and group work. I do that privately, and I also do that within my various roles. And, but this is like my big passion of all passions, which is like the facilitation and the design of workshops and groups and psycho-ed programs, both for people with IDD and those of us supporting them both in mental health and in developmental services sector. I do believe that education is the key to all of this, and for all of us to be on the same page in the way that we approach these really complex support needs, because, as time goes on, our clients aren't getting more simple. And so it's imperative for all of us to really to rest on evidence-based practice and in the clinical wisdom of people who are doing this sort of work effectively. So the question is, and this is something that I tend to we tend to discuss when we're doing the ASIST training. So like what brought me to teaching about suicide and suicide first aid? The point of asking this question, of course, is that I have to be comfortable talking directly about suicide. So I'll tell you a bit about my story. I came to teach about suicide. I'm Jewish, as I mentioned, with my mom and the Sobeys trip about the meat. And in Judaism and similarly in Christianity and in Islam, suicide is not allowed. So there's this huge stigma around it, right? You have this tradition where people who have died by suicide in the Jewish faith, they're sort of buried on the outskirts of the cemetery, and there's this real separation of people. And I, having been an adolescent who struggled with her own mental health issues and her own suicidal ideation, and having had family members who died by suicide, to me, it was a really peculiar thing that there's this huge topic and this huge thing that's so heavy, and yet we don't talk about it and we don't address it fully. So when given the opportunity to teach about suicide within the DS sector, I obviously jumped at it. And, there's this real element of like, I don't know, it feels nice to be able to address things directly rather than to skirt over it or put it under the rug or to ignore it or to say, oh, well, that person, oh, they were sick. Let's address what the issue was so that we can speak to that issue and hopefully help to make it better. So that's my story. And I think, if you should go ahead and train and go through these sorts of programs where you learn to address people and to intervene when a person is at risk, at imminent risk, it's important to consider those things. Why you got here, how you got here, and how your history affects your attitudes as a caregiver to a person who's at risk for suicide. I'm also not very good with technology, famously. Like, I don't know what I'm doing. So excuse me if I have problems going through the slides. Here we go. So this will be something where I'll have Deanna sort of monitor the chat box. So we're going to start off our conversation, okay? So I have the first question. Let's talk about, why are you here today and what are you hoping to learn? You can either write in the chat box, you can unmute yourself. And you know what, when you're answering that, just let me know if you're certified in ASIST. That would be nice to know, just as like a thing for me to wrap my head around how I approach this. Bueller.
Oh, sorry. Hi, Michelle. Sorry, my name is Vicky. I work for an organization known as MetaCenter. We support adults with developmental disabilities.
Of course, and, I know Meta well.
Yeah. So I'm just hoping to get some information about kind of the thought process that kind of goes behind, suicide and suicidal ideations. I have several clients on my caseload where this is a common theme, and just really frustrating because when I went to school, it wasn't something that was spoken about or even taught at the time. Finding it very challenging in my line of work to kind of deal with this, because I don't particularly have the training. So that's what I'm hoping to get out of this.
Honestly, good for you, Vicky. Like, I think like acknowledging where your gaps in knowledge are as a support worker, and then, or as someone who's working with people with disabilities, and then sitting in on those trainings is imperative. Okay. Do we have anything in the chat there?
Yeah, so the chat, basically, Kim just would like to know how to best support clients and family if needed, as I think Vicky pointed out. And we have another chat that basically said, I just started working in this field and would like to know how to support our clients. And Petra, I'm here because of a number of people we plan with have had suicidal ideation. So I'm hoping to learn what resources we can suggest to them and their allies. Right. Another question is, I work with individuals who have had thoughts of suicide and would like to learn how to support during this difficult time. I've been previously certified. So this is Dana Whitehouse. I've been previously certified in ASIST and hoping to gain current knowledge information. You know what that means, I'm assuming?
ASIST is the Applied Suicide Interventional Skills Training.
Okay.
Yeah.
Beautiful. Francis Moore, good morning. I'm working at Community Living. I'm hoping to learn more about specific strategies with IDD community. I completed ASIST training a few years back. Would love to get recertified. And a few more here. Hi, everyone. I'm certified in ASIST. I work with urgent response, and many of my clients are in crisis and have been diagnosed with DD. Some of this crisis revolves around suicidal ideation. It's Maya and Alicia. I would like to understand more about where the clients is coming in from in their darkest times and how to help them move forward. Alma, I'm an assessor with DSO. One of the questions on the assessment is directly on the questions of assessments directly, does the person with IDD have thoughts of suicide or have attempted suicide, and what support they need to prevent it? I also am certified in ASIST and would like to know resources.
Wonderful. Thank you. So Alma and Samaya and Francis and Dana and all of you who have your certification in ASIST, I am going to rely on your wisdom as well, having been trained in this, to interject. So I expect to see your name pop up, all of your names pop up a lot. But it is good to know. With regard to ASIST training, those of you who are curious about recertification, It's every 2 years you have to get recertified to be up to date on the information. As far as I know, we're not doing in-person trainings just yet, but I wonder if that'll change given that everyone's getting their 3rd dose these days. When that time comes, myself and the folks who I usually train with will probably like be putting forth some opportunity to train in the DS sector. So I'll disseminate that information to Deanna so that you have that, because it is important to stay informed. Unfortunately, given the brevity of our time together this morning, we won't be able to do any real like practical skill training. It's more of a theoretical approach to it, but I'm hoping to answer at least some of your questions around it and offer some tips that'll make it easier to manage those folks in your caseload who might be struggling with suicide and suicidal ideation. So one more thing. Given the nature of this topic that we're discussing today, sensitive information will likely arise. I mean, this is something that happens when you're talking about suicide because it's such a personal thing. We're obviously talking about it in regards to the people that we're supporting, but when you're doing the ASIST training, you're thinking about this not just like wearing your hat as whatever you're doing professionally, but just as a community member in general. The goal is always to have a suicide safer community, to have as many resources and people in place that we can help to stop people before they go through with their plans of action. So please be respectful to those who share today. Keep their information and stories private. Again, know that I'm a resource. If you're at all uncomfortable after this, please do not hesitate to reach out. I'm happy to help you navigate whatever resources or to, hang out until we can make things safe for you. So those of you who've taken ASIST will recognize this slide here. So when we talk about reported suicide, it's a very difficult thing to understand really what the numbers are with regard to how many people die by suicide a year. So this is the picture in Canada for the year 2020. So our population here is 38.01 million people. Reported suicides in the year 2020 were 4,000 deaths for that year. What we know is that there's a 5% to 25% unreported suicide. So we're thinking, and it would be an additional 200 to 1,000 people that didn't get reported. So those are the people that, they say, oh, they died in a car crash, but really, it was an action that they tried to kill themselves and they did that. Oh, oops. So then we also have suicidal behaviors, which don't get recorded again as such. Those people are coming in with SIBs and it might be recorded otherwise, or that they had an accident, they fell down the stairs, any number of things. So you're looking between 160,000 and 400,000 people per year. So it's 40 to 100 times greater than the actual number of suicides. So that's how many people are attempting to die by suicide. And then we know also that, for every one person who is struggling with this or wanting to kill themselves, there's a huge number of people who are affected by this. So I'm talking about like caregivers and loved ones and, housemates and all that sort of thing. What's more than that is that people who have survivors of suicide, and I don't mean those people who tried to die by suicide and then it wasn't completed, but rather, not completed, but they tried to die by suicide, but it wasn't fatal. There are people who survive them and then they become at a higher risk for suicide as well. So that sort of conflates the number. And we know that approximately of the general population, 11% of people have active thoughts of suicide. So in Canada, that means there's about 4,180,000 people currently who are struggling with suicidal ideation. Now we'll find out when we go further on to the slides and we look at the statistics with regard to ID and DD, that number is about, it's 23% to about 26% of the population of people with ID and DD who are struggling with thoughts of suicide. So it's an enormous number. It's an enormous public health issue, but one that we really can't address properly until, number one, we get rid of the stigma associated with it, and number two, have proper reporting measures, or that people feel comfortable enough to be able to talk about those things. And that's a slow process. and this is again a plug for Living Work. I just think it's advantageous for everyone to be on the same page with things when we're addressing these complex things. Living Works, like the ASIST program, sort of like the most accepted international program. So they do it all over the world. So, this is sort of a shared language, even though it's in different languages, but it seems to be a first aid measure that's effective. So if that's something that your agency needs to do, I really do encourage you to look into this training. So this was taken from StatsCan. So approximately 11 people died by suicide each day in Canada. And again, it's about 4,000 deaths per year. 1/3 of those deaths are among 45 to 59-year-olds. A high majority of the deaths are really people who are older and young people. It's the second leading cause of death amongst youth and young adults, so aged 15 to 34 years old. The rates are 3 times higher among men as compared to women, even though rates of depression are higher in women than men. And here down here, I mean, I'll send out these slides so that everyone has a chance to review them on their own. But on the bottom here is just sort of the rates by 100,000 and the breakdown for the age. And you'll see that for hospitalization, you're more likely to be hospitalized if you're younger. As you go down, while you have the same sort of risk of suicide, we're not catching it as much, and people aren't being hospitalized as much, and maybe they're less non-fatal attempts, and those people who do attempt end up dying by suicide. I think that's okay. Then the next one is another infographic. Oh yeah, and I got that from Canada. The government of Canada gave me this. So when we talk about suicide thoughts, plans, and attempts, and you're looking at people within Canada, about 11.8% have reported to have thoughts of suicide at some point in their lifetime. But like I said before, people are not always honest when they're answering questions to do with this subject matter, right? I mean, it's something that people carry a lot of stigma and shame about. So these numbers, while they're important, they're also kind of meaningless, unfortunately. We know that 4% of people report having made a suicide plan in their lifetime. So again, it's hard to ascertain. But we know that on the bottom here where it says 7 and 3, so it's mostly people in a lower income quintile. So people, lower socioeconomic status versus people in a higher tax bracket. And again, 3.1% people of the population have reported making an attempt in their lifetime, and it's very much underreported number. So, but this is what we have in terms of stats. Now, already suicide is something that's not captured well. Suicide rates and plans and ideation within the population of people with developmental and intellectual disabilities is super not well captured. Like, we have really no bloody idea, because those, we've all been working here for a while. This is not the most highlighted population, even though overrepresented in every which way in terms of complex care and these sorts of more vulnerable groups. But unfortunately, it's not captured. So the higher risk populations that we know, according to stats, I'm sure some of you can guess who will show up here: men and boys. There's an issue around impulse control, and you're more likely to have problems with like your executive functioning and your capacity to manage your impulses if you are born male as opposed to female and have that sort of hormonal profile. That's just it. People serving federal sentences, that also includes forensic mental health, survivors of suicide loss, and survivors of a suicide attempt. Like I mentioned before, it's not just the folks who had a non-fatal suicide attempt who are at a higher risk of dying by suicide, but rather those people around them who have supported them or who have survived the person who has ultimately died by suicide. Some First Nations and Métis community, especially among youth, and this is something that fortunately I think in recent years we've managed to highlight a little bit more. I'm just like, oh my God, I only have a half an hour. Geez Louise. Okay. Then we have all Inuit regions in Canada, Women have higher rates of self-harm. We know that, but not higher rates of suicide. But self-harm can be a risk factor for suicide. Now, it's sometimes an accidental thing, unfortunately, especially when it comes to the misuse of psychopharmaceuticals. We've seen that quite a bit, but it's an issue there because you can't really capture the intent of the matter. So it's a hard thing to understand. And then we have, thoughts of suicide and suicide-related behaviors are more frequent among LGBTQ. So like among lesbian, gay, bisexual, trans, queer, and two-spirit and questioning folks, as compared to their peers. It's a real issue, especially in the trans community. And I think there's a lot more emphasis on training and understanding within the queer community these days, which I think is a really nice thing. In general, again, I can't say this enough. We just need to be a suicide safer community altogether, right? And there's also when you look at the high risk people, I think that's it becomes pretty tricky because we're like, okay, so I'm looking specifically for those people. So you're really monitoring those folks. But in focusing too much on these groups, you might actually miss people who are also at risk. So I give this to you with that in mind. Just because a person doesn't fall within any of these categories doesn't mean that they're not at risk for suicide. And it's something that you need to remember and have at the back of your head. Like anyone could be at risk, right? Okay, Jason, you're admitted. Okay, next. Keeps popping up on my screen, so I'm admitting and teaching. So let's talk about gaps in research. This is while the whole thing is a depressing topic, this is the most depressing topic for me. So there is very little data available on suicide amongst people with ID and DD. And that speaks, again, just to the general gaps in knowledge for people with ID and DD. I mean, I have my master's of social work. Do you think that there was a specialty in this population? Absolutely not. I mean, for myself, I then tailored every single assignment, every single speaking, everything I ever did had to do with this group of people. But did I get a specialization in that? No. And the same goes for psychiatry, for medicine, for law, for all these sorts of things. And that speaks to our need to advocate. And as people who are aware of and who are deeply immersed in this work, I think we need to start speaking up with those of us who are affiliated with professional colleges, especially. But what we do know is that there is a high prevalence of suicide risk factors among people with ID. All of the risk factors that make the general population more likely to die by suicide, they got it all and more. So we know that depression rates are substantially higher in this population, but there's little attention in research and literature about suicide. Suicidal ideation and gestures are 100% underreported in this population. So Pacha and his colleagues he's from Finland, did a study of folks with IDD, like adults, and found that the reported rates of suicide are a third that of the general population. So already the reported rates of suicide in the general population are completely underreported. So you can imagine. But again, it doesn't mean that this population, number one, isn't going through those suicide behaviors. It's not like they're not having suicidal ideation. It's just that we're not capturing it enough. So a problem. There was another study done by, hold on, what am I doing here? How come I can't see? Oh, good. By Walters and their colleagues, and for subjects age 18 to 21. So just adolescents with ID in the States. And they found that when they were reporting suicidality, it was associated with family discord, bereavement, history of physical and sexual abuse, and the other elevated risk factors associated with having an ID or a DD. And that, of course, we know that, of reported instances of abuse within people with ID and DD, it's about 87% of folks will have experienced abuse at some point in their life, and that being a hugely important risk factor for suicidal ideation. Most of the studies in this population described a life event, so family member death, abuse, rejection, dual diagnosis, or depression as the important risk factors in determining whether or not that person was at risk for suicide. So this, if there's a practical take-home message when your folks are going through these things, and I know we always do rally around our people that we're supporting, obviously, disability. But within these particular circumstances, I think that's when we need to be a little bit more cognizant of what's going on with the folks that we're supporting. How come this isn't letting me go? Okay, good. So people with ID and DD share some risk factors for depression with the general population. Again, abusive experiences, poor social supports, unemployment, and social disadvantage. Of course, we know that as compared to every other vulnerable population, we have the highest rates of unemployment with people with cognitive and intellectual disabilities. Now, females with IDD experience higher rates of anxiety and depression as compared to males, and which is similar to the reported rates among people without disabilities. So what does this mean? It means that we're still as confused about them as we are with the general population. There's no, like, we can't tease any of this apart until people are a little bit more comfortable sharing and until we deal with the stigma associated with it. So I took a lot of this data from, I cannot pronounce that person's the first person's here last name, I can't. So I'm just gonna say these guys did some studies and they found that people with ID are at least as likely, if not more likely, than the general population to develop both depression and anxiety disorders. So the prevalence rates are between 2.2 to 15% for depression and 3.8 to 17% for anxiety. Now, keep in mind that for the general population, it's about 2 to 5% for depression and about 2 to 5% for anxiety. So when you're looking at sort of like the top end of that, that's a huge increase as compared to the general population. And the disparity, of course, is due to all circumstances which make this population extremely vulnerable. You know, we have biological predispositions towards some mental health issues. There's increased exposure to adverse psychosocial experiences, right? They don't have the same opportunities, they're limited. And also there's this limited cognitive ability. And I will say more than that, there's also difficulties in emotional regulation and capacity to support complex emotions. And if a person is struggling with someone without supports in a circumstance where resources are limited for them, they end up being at a higher risk for suicide. Prevalence studies. So there's a few prevalence studies. They don't necessarily deal with the entire population, but rather with community and outpatient psychiatric subjects. And these are all Toronto-based. So this should mean something to us. So Merrick, Linsky, and Candle did a sort of assessment. I think it was about 500 adults with ID and DD in both communities, so like within the DS sector, and utilizing outpatient psychiatric reports. 34% of those people reported that life was not worth living sometimes. 23% were actively thinking about killing themselves, and then 11 of them had attempted in the past. And of that, 6% were psychiatric. So it's a lot of people. And again, it's higher than the general population. And this is even with the added layer of it not being reported well. So suicidal behavior is most common in people with mild to moderate ID, but extremely rare in persons with severe and profound ID. But again, it's very difficult to diagnose depression in people with moderate to severe ID. And we don't really know how to assess that, especially with the barriers as it comes to communication. There was another study through U of T, and they looked at 98 adults that kind of range between borderline intellectual capacity to moderate ID, but again, in community and outpatient settings. And they found that 27 reported that life was not worth living sometimes. So within the sort of same percentages as the study by Merrick, Linsky, and Candle. But primarily, it was people with a mild developmental disability who were more likely to report. And again, 8% of those people reported that they think about it most of the time. So they're at imminent risk. And the majority of those folks that reported had a mild intellectual disability. So I don't know what that means, but here we are. So, okay, so we know that it's a problem. So this quote says, while there is a growing recognition that people with IDD need access to timely and effective mental health care, barriers to accessing services are still prevalent. One barrier to accessing care is that people with IDD are unlikely to self-refer for services, which necessitate that a caregiver must recognize and facilitate the referral process. So this is exactly why you're sitting here with me today, because we do things differently than other sectors, don't we? It's like, I love when we maintain boundaries, when we're like, okay, I have a professional relationship with this person, and yet like you're helping them with the most intimate parts of their life. So obviously that gets skewed from time to time. And it happens because in order for us to effectively do our jobs, we have to sort of become immersed in that person's life, and we have to know them well enough to know when they're showing signs of these things. And I think that's why a lot of you are here today, to sort of figure out or to tease apart when to do this. So let's talk a bit about it. So before I go through, you like this? You like the weird picture, Deanna? It's weird. It's a collage. My friend made it. It's strange. Okay, so these are some fundamental truths. If you're going to intervene with a person's who's at risk for suicide, this is one of the fundamental truths you have to believe. So most people at risk want to live, and there are good reasons to be hopeful. Again, if you're talking to a person about how they want to die by suicide, number one, they haven't killed themselves yet. So there's a reason that they're talking to you. And if you can't work with them to find a reason to want to keep safe for now, that's a really good thing to anchor yourself to. And you can even point it out. Listen, we're talking. You're talking to me right now. There must be something that's keeping you here. And let's talk about it. Some people at risk hide from view, but most all really want to be seen and talk about suicide. That is a typo, but this is also true. Again, if a person has really committed themselves to wanting to die by suicide, they're going to do it, unfortunately. And, we are like, we have the capacity to make change and we have the capacity to help, but sometimes a person's illness, unfortunately, dictates whether or not that happens, and we can't be to blame for it. But if they're talking to you again, they want to talk about it. If a person's talking to you about suicide, some part of them wants to live, even if they're unaware of it. And part of our job, I think, as support people, is making them aware of that. If given help, life will usually prevail over suicide. And when offered in the context of an intervention, so those of you who are ASIST training, even something as seemingly small as wanting to have a reason for living can succeed against suicide. That's such a powerful thing too, right? If a person says to you, I want to live, that's still a desire to live, right? Like you take aside, excuse my language, but like put aside the bullshit. They're just saying, I want to live, right? So fundamental beliefs, there we go. So before you intervene with anything, like I said before, when I talked about how I ended up here, you've got to be aware of what your attitudes are with regard to suicide and with regard to, there's attitudes with regard to the morality around suicide and dying by suicide. And that's just life, right? We can't, in the same way that when you're working with people, like you have to address your biases, you have to address sort of like what you think and what you believe about things, and put that in the forefront of your mind. Number one, to educate yourself, but also number two, to be aware of how that influences the way that you're working with people. So our personal attitudes can affect how we intervene when someone is thinking of suicide. Even if you're just like, oh, I don't think anything about suicide. The lack of an attitude, by the way, is also an attitude. So we need to be self-reflective. We need to recognize how feelings about and personal experiences with suicide might impact you in intervening with someone at risk. Like, let's say you had a loved one who died by suicide, and there's some transference there, and you can't stop thinking about that person. That might affect your intervention with the person. That might affect your capacity to support them when they're going through something like that. So be aware of it. And just because you can't intervene in that one-on-one with a person doesn't mean you can't source out resources, doesn't mean you can't be part of the support team around the person. But just know what your capabilities are and where your comfort lies. Identify beliefs that may assist you to be direct and comfortable in suicide situations. Like let's say you're a person of faith and you're intervening and you're working with a person who also is a person of faith. It might be beneficial to you to have that shared common ground. But again, I use that sparingly and with some finesse, right? You can't say, well, you can't kill yourself because God said no. I don't think that's necessarily going to be helpful, because probably that person is dealing with a great deal of shame because they want to die by suicide, and that directly goes against their religious beliefs. But certainly to understand where they're coming from and to be empathetic around their pain around this subject matter is so helpful. You got to identify beliefs that might help you to be more flexible in meeting a person's need and for guidance and for care. And again, you wouldn't be sitting here with me on a Friday morning talking about suicide if you weren't a caring and empathetic and kind person who wants to support other people. So this is a good thing. I believe everyone here is flexible. But this is also so important. We got to learn how to talk openly about suicide and life assisting. It's like the same thing when, I don't know if those of you who've sat in with Deanna and I, like when we're doing our sex ed training, like if you can't say like penis, vulva, cock ring, anal sex, then you can't talk about sex education. The same thing goes with suicide. If you can't say like, do you want to kill yourself, or are you thinking of dying by suicide, you cannot properly intervene. What's this? Oh, okay. So I like how I never know what's ahead. It's fine. This is fine. My life is fine. Okay, so within the context of an ASIST intervention, we talk about the beginning part of it is always exploring invitations. Now, why do we call these exploring invitations? Because people are inviting you to talk to them by showing you in different ways with their actions, with their feelings, their physical appearance, and with their thoughts that they're thinking of dying by suicide. So I don't need to really go through all of it, but I'll pick out some takeaways. Like, for example, you have a client who never once before drank to excess, or now they're doing drugs. It's something that you might want to address, especially if they're also, expressing that they're sad or they're lonely, given the COVID context, like things are really up in the air for people. A person who all of a sudden has gained a ton of weight or lost a lot of weight. I mean, don't just do it because the person all of a sudden gained weight and like they're eating challah, but they're happy. But if a person has done that and they're expressing these really profound thoughts of sadness and they're doing all these other things like withdrawing, it's something you might want to address. Again, I'm going to send out these slides and this will have this here, but I do implore all of you, if you're interested in getting into the nitty gritty of it, I think, going through like a proper training course and learning these things is probably a good thing to do. But here's my question. And this is, I want to hear your answer because I know what I would do, but how would you ask if a person was thinking about suicide? Like, how would you ask of a person if they were thinking about suicide? What words might you use? No one wants to answer me.
Yes, feel free to add to chat.
Oh.
Yes, go ahead.
Hi. Yeah, hi, it's Alma. And as I said initially, we do have a question building in the assessment. So what I do ask is, I don't go around the word of suicide because most of our people with IDD may not even understand what that means. I say, have you ever thought about willing to end your life, killing yourself? And I expressively say those words that are sometimes traumatic for parents to hear. I could feel like they are not comfortable with me asking that direct question, but I do. And some of the times I have heard, responses of people wanting to and having a plan. So, and that was a big surprise right there and then at the assessment process. So yeah, I asked a direct question.
Excellent. Thank you, Alma. That's you hit the nail on the head, and you said exactly what I wanted you to say.
Well, there is no other way. There is no other way.
There isn't at all. There isn't at all, right? Like, and I think your point, and I didn't even think about it, your point around not using the word suicide because maybe they don't have an understanding of what that word is, or maybe they haven't heard it before, I think is a really good one. And similarly, like your colleagues here, like Naomi says, have you ever thought about killing yourself? Petra Ann says, are you considering ending your life? Christine Zgola says, are you considering ending your life or hurting yourself? I've noticed, I'm worried about you. Are you thinking about hurting or killing yourself? Okay, so the idea, I wouldn't use hurting yourself. That's a thing I think I would reserve for another discussion because that's a bit too ambiguous, right? those of you who have gone through ASIST, and not to point out anything, obviously I'm not looking here to make anyone feel bad, but it's just a learning opportunity. But when you use the terminology hurting yourself, you're leaving room for interpretation, right? Maybe they are thinking about hurting themselves. Like maybe they're thinking of going on a 3-day drug bender. That's going to hurt themselves. But was the intention for them to die? So I think being really concrete in those languages, especially knowing that the folks that we work with have difficulty with more shades of gray in language, just saying, are you thinking of ending your life? Do you have a plan to end your life? And Alma, that point around that being part of your intake as a DSO assessor is a really good one too. And it's something that we do when I'm seeing new clients in my service. It's on the first day you're doing a suicide risk assessment. And I think that, within the DS sector, since I've been sort of working with that hat on, I remember that that's not something that we usually discuss the day of. And I think that's something that needs to change. Like when we're seeing someone in our service for the first time, we got to ask about suicidal ideation. We got to ask about self-abusive behavior. We have to ask about like homicidal ideation, honestly, or like any sort of aggressive attention, because like these are the folks we're serving, right? And if we don't ask, and if we're too nervous to ask, we're not going to capture those things.
Michelle, sorry to interrupt. I
Yeah.
also got the good idea of, because we're doing the assessment, the SIS assessment,
Yeah.
supported density scale for all individuals who live in Ontario with IDD.
Yeah.
That could be a good idea to kind of also, if anyone wanted to launch themselves into a research study about people with IDD and what is reported, that could be a good starting point.
That's actually an excellent point. Yeah, that's a very good point. Alma, thank you for that. That's very good. Yeah. So again, the whole point of this particular question is like, how would you ask a person if they were thinking about suicide? You just have to ask directly, right? And there's a reason. So sometimes the kindest thing you could do is to ask directly and explicitly about suicide. Oftentimes people have not had the opportunity to discuss these feelings before, or they haven't been asked before, or people have noticed they've been sending out these invitations, showcasing that that's something they're thinking about. And think about this, like, let's say, once when I was doing my master's, I sent out a bunch of, I booked a karaoke room. I thought like 25 people were going to come to this party. Like 5 people came. No one responded to my invitation. I felt like shit. I can't imagine what it's like to send out invitations or like these requests to have someone talk to you about suicide, and they're not asking you directly. That sucks. That's a terrible feeling. And I think asking a person clearly and directly if they're thinking about suicide is a way for you to demonstrate to them that you're comfortable hearing about it, that they're not going to scare you're not going to be scared off by the pain, because that pain can be ugly and it's hard to deal with, right? But suicide is, it's about pain and it's about loss, right? There are any number of factors that can lead a person to want to die by suicide. And wanting to die by suicide is wanting to end pain. And I'm hopeful that if you ask a person, like, are you thinking about dying by suicide? Follow-up question should be like, what led you to this point? What are the circumstances that made you consider suicide as an option for yourself? And hopefully that person who's telling you that story has some semblance of relief from their pain when they're talking to you about it, because they're kind of, they're taking it off. And that creates this condition for hope and for uncertainty, right? Like if they're like, okay, like I feel good in this moment, it's this uncertainty that the pain's going to last forever. Maybe there is hope about it. But it requires 2 things of you. Number 1, you have to be patient to listen. It's not about you. It's not about your story. It's not about your feeling. It's not about anything to do for you. You are there to ask questions and to keep them talking. They don't want you to hear say, oh, you have so much to live for. They need to tell you what they have to live for. But you're not going to find out what that thing is if you don't allow them to speak. And then you need persistence. They might not want to, they might be hard to sort of, a hard nut to crack, but it's a good thing to think about. Like, it's hard to talk about those things, but if they're sitting with you, some part of them wants to be talking about it. So you have to be persistent. Be mindful of your body language, be mindful of your behavior, be mindful of how anxiety is being expressed for you. Deanna, I might need like 10 more minutes to finish up the slides. Okay. Oh, actually, no, I don't. This is part of the thing. So what are the next steps? Like, what do you do, right? You talk to a person, they're telling you they want to die by suicide. They're telling you their story. Maybe they're telling you, you know, I wish that I had a reason to live, or maybe they're saying, I really want to die, but you know, I love my mom and dad and I don't know what to do. Or you know, I've been thinking about killing myself, but I can't. I have my cat at home and I can't leave my cat. Or I really enjoyed the program. What do you do? Again, this is you talking about me. What are the next steps?
Okay, I'll monitor the chat here. Peter Ann says, I find in planning when I ask questions, people tell to be honest.
So you mean in terms of like, what planning are you talking about, Petra?
Sorry, I'm talking about person-directed planning. You know, we don't necessarily talk about those questions, so we probably should. But I find when I ask people are usually very honest, and they are respectful, and they feel a responsibility to answer honestly. So if you ask the right question, I find you will get an answer.
Absolutely. Absolutely. And I think, you know, planning is an interesting thing. Like we use in ASIST the term like a safe plan. So once a person lets us know what they're thinking about, and if they're acquiescent to it, like we would build a safe plan with them and sort of try to keep them safe for now. I think one of the good things that ASIST does is that they give you kind of a third option. It's not life and it's not death. It's just like, can you just like agree to keep safe for now while we figure this out together? Is usually a good thing. And some of you might be part of the team that helps to support them in following through to that plan. Some of you might just be the person who hands that individual off to another team that helps them manage their mental health. But you know, it gives people less of that anxiety that they have to be certain, like, oh, I don't like, because they still don't know if they want to live, right? What else do we do? What else are the next steps? What else might we do?
Sorry, it's Alma again. So if that comes up into an assessment, so that's what usually the person would be sitting, you know, across with other caregivers. So that could be a surprise to the caregivers to begin with. Mm-hmm. And we delve a little bit more into whether those were attempts that didn't end in fatal, you know, outcome. So we see what happened before, what attempts the person have done, and what are they thinking right now at that moment. Do they still have a plan? And what does that plan involve? And for one individual who was sitting, I was sitting in their home and with their mom, you know, and mom is they are immigrants, but the person speaks English way better than mom. So the person had to translate this to mom.
Right.
And at a certain point, I think mom understood that this was, you know, the thoughts of suicide that this person had. And as I'm delving in more into what they thought and how they thought they're going to do, this guy just says to me, well, I'm trying to find a rope how to hang myself. And, you know, as he's going, like he's looking into the ceiling and he's kind of, you know, the whole point was for him to find a rope. That's all what he's lacking, right?
Yeah. You know,
yeah, go ahead.
I think also it's important, like, and I like that you mentioned the rope. If they have a plan, it's also about disassembling that plan, right? Like, you know, if they're trying to find a rope, like let's work with the family to, you know, maybe put away belts and ropes and all those sorts of things for the time being. Let's keep them safe. Maybe put that, like, you know, get them admitted to a hospital under a Form 1 for 48 hours.
Yeah.
Yeah.
So we do talk about the safety plan. Mm-hmm. I would give, if this is not the imminent risk, you know, then I would also give the caregiver and the person themselves numbers to call, like the distress center, the Elizabeth, I can't remember the full name. So there is a paper with few numbers that the person can talk to if they don't feel comfortable to talk to people who they used to, people Absolutely. Who they go to. Like if they don't feel comfortable to talk to a family member or a teacher at school or a mental health worker that they used to, so those are supplement.
Absolutely.
Yeah.
I think also like it would be irresponsible for us to sort of leave them like, I always want to hand it off to someone. Do you know what I mean? Like if you're working with a person individually, always have like a family member or a person who they work with or whoever who sort of is taking over for your responsibility, right? So I like that plan, leaving them with resources, but also with a person to sort of manage it. So we have here, listen and find out about their strengths, encourage their strengths. I think that's an important piece of it. I think that encouraging strengths also sort of helps us get to a point where maybe like they have some motivation to not want to die by suicide. We have Lily here, says, figure out if they have a plan, call for emergency, get the individual to the hospital in case you leave and they do kill themselves. Again, that speaks to my same point. Like we can't leave them, once we know that they're at imminent risk for suicide, we are disassembling the plan and we're making sure that we have another person who's taking over for us. Petra, you have a question.
Sorry, I'm just thinking of, Alma too, and in my work at planning kind of thing, because as I say, it is identified, say on the CIS, and then I usually pick it up because I don't read the CIS on the ASR kind of thing. But I'm thinking like I work for Community Live in Toronto and we have an internal database and we have like at the top, like priorities kind of thing. But I'm thinking like it takes a village and we're all sort of working with the same people, in different ways that like, to me, I feel like I need to take this more seriously. And, like people that have identified that at the DSO level, I think that should sort of be flagged. And hopefully in our new database, we can maybe talk about that, so that anyone working with them knows that that's a possibility or whatever, and that we address it in all of our work. Am I making sense?
Yes, you're making perfect sense. Yeah, but I think you're right. Like I think the discussion around suicide and suicide risk really needs to be at the forefront when we're meeting people for the first time. I also think like it's important. I think sometimes we tend to like skip over people's when they say that they've had some thoughts of suicide. And I know it seems insensitive, but I've seen it happen time and time again. A person says, oh yeah, well, I've thought about killing themselves. And we as clinicians or as people working within this field might we like seize up, if we get really uncomfortable, we're like, oh, that's too bad, and move forward. I think that comes like we need to really sit within our own anxiety. And like I said, it's not about us. It's not about what we're comfortable with. It's not about our stories. It's not about our history. It's about that person. And, if it's, if you save a single life, that's worth it, right? And as anxious or as uncomfortable as you feel, like, I'm sorry, but that's part of the role, right? Especially in the context that we're living in right now. So we have a question here. What can we do for those we support who do not use words, who might be feeling or considering suicide? That's a tricky question, Naomi. It depends how they communicate, right? Like, how are you asking them other things? If there's a concern that they're showing signs of suicide, I would certainly bring it to the attention of their support team. I mean, oftentimes when people aren't using words, or maybe they have those challenges in communications, we have a whole slew of people that we're working with to help support that individual. And we got to address it. Even if you think you're being silly, like even if you're like, oh, like no one's going to believe me, bring it up, because you might be the person who's actually picking up on that invitation that person is sending. So feeling comfortable to address all of these things is like at a baseline, the most important thing that you could possibly do. What do I have next here? So here are some resources that I have here. Just like, and this I got from like the Government of Canada website. I do have a sheet that I prepared once for another agency, and I wonder if I still have it lying around in my files of sort of like specific resources for specific issues. If I can find it, I will send it with the slides so that you guys have access to it. I'm sure it's somewhere. I don't know. Yeah, Deanna's giggling because somewhere, when I say somewhere, like Lord knows where it is, like on a computer that I broke like 15 years ago in my basement. We don't know.